Good morning and warm welcome to Online Anaesthesia Postgraduate Teaching Program on Zoom platform, sponsored by Akrulla and hosted by A1 Logics and supported by Anaesthesia TV. In the month of November, we are covering the left out topic. Today, we are covering the lower limb blocks. For that, we have three eminent faculties in our online anesthesia. So the femoral block will be covered by Dr. Vishnu and sciatic nerve block will be covered by Madan Mohan, and popliteal approach of the sciatic nerve will be covered by what's the name, sir?
Vinod Kumar.
Vinod Kumar. So today's session will be coordinated by Rajesh Jayaprakash, sir. Over to you, sir.
Thank you, sir. Thank you. Good morning, one and all. As sir told, we have three important topics, and which is very useful for the postgraduates, not only for the clinical practice but also for the theoretical purposes too, because we get a lot of questions related to that blog. And a lot of updates are happening with regional anesthesia nowadays. So everyone is very eager to hear about this lower limb blocks, especially in this era of anticoagulants and the fate of epidural, which is going out of the field. So which is the upcoming area is lower limb block. So we have three eminent dynamic young speakers today. The first topic is femoral nerve block, lateral femoral cutaneous nerve block, and adductor canal block, which will be covered by Dr. Vishnu Kumar, who is a good friend of mine. He is a consultant anesthesiologist from Sri Chandrasekhara Hospital, Hosur, and he had done his PDCC course in interventional pain management from a renowned institute from Lucknow, and is a faculty in so many workshops related to regional anesthesia and pain medicine. Welcome, Vishnu, for your topic on femoral nerve block, LFCN, and adductor.
Thank you so much, sir. Thank you, sir. Sir, can I share my screen and start off, sir?
Yeah, you can share your screen.
Yes, sir. Good morning, everyone. And sir, thank you very much for the opportunity. And today we are going to speak about the ultrasound-guided femoral nerve, lateral femoral cutaneous nerve, and adductor canal block. Sir, is my screen visible, sir? And am I audible, clear and loud?
Yeah, you are audible and visible.
Fine. Okay, sir. So this is a very important topic, students, and I have made it as simple as possible so that you can understand. First, when we talk about these blocks, first I'll be teaching regarding the pertinent anatomy and the dermatomes, myotome, osteotome involved, and then I'll be showing you the pictures of how you place the probe and what is the anatomy that you're seeing. And last, I'll be showing how do I perform my blocks and the simple method. See, all these ultrasound guided nerve blocks, if you take even a femoral nerve, there are too much of literature, and even one day will not be enough to talk. So much of literature is there. But as far as the PGs are considered, I want to speak about the evidence-based thing, and I want to show you the practical approach, which if you follow this, you're going to get 100% result. Okay, so let's go into the topic per se. So the first thing is femoral nerve block, and here we have the pertinent anatomy. So first, this is the cross section of the femoral. Let us suppose this is the cross section of the femoral nerve of the right thigh below the inguinal crease, okay, or at the level of the inguinal crease. Here, this is the skin and subcutaneous tissue below, okay, and the yellow color thing is the femoral nerve, okay, and this femoral nerve is present over a big muscle called iliopsoas muscle. Okay, above this femoral nerve, you have got a fascia, which is called as the fascia iliacus, and above this fascia, we have got another fascia, which is a fascia lata. Okay, and we have got a we have got a vascular structure, femoral vein, femoral artery, and these vascular structures and the lymphatics are enclosed by a separate fascia. So our goal when performing a femoral nerve block is that you have to bring the needle from the lateral to medial portion, and you have to cross both the fascia lata and fascia iliaca. You have to place your needle here so that your drug is going to be deposited close to the femoral nerve. Okay, so remember the structure, and you have a mnemonic called navel: nerve, artery, vein, empty space, and lymphatics. Okay, so you have to remember the navel. First point to remember in case of lower limb is considered whenever in case of lower limb, the nerves are always located laterally. Whatever the nerve you name it, femoral nerve, popliteal sciatic nerve, everything, even in the foot, ankle, all the nerves are located lateral to the vascular bundle. Okay, so I hope you have understood this image. And now let us go. So the clinical indication. First, the femoral nerve block was introduced to provide an on-arrival blocks when the patient had a hip fracture or when the patient had knee injury. So this is the osteotome. If you see, femoral nerve is going to cover the hip joint, at least partial, like 60% of the hip joint innervation is done by the branches of the femoral nerve. And similarly, like almost 40 to 50% of the knee joint has been covered by the branches of the femoral nerve and medial portion of the ankle. Okay, but nowadays with the advancement, so we are doing other blocks like 10G block, which is an effective for hip fracture analgesia, all these things. And these are the myotomes involved. So myotomes means muscles, basically rectus femoris and vastus lateralis, vastus medialis, sartorius, and adductor muscles. Okay, and this is the dermatome involved. Okay, so whenever a plastic surgeon wants to take a split skin graft, always give a femoral nerve block if they are taking split skin graft at this area. So this will give a wonderful analgesia, and even that would not be contracted by a paracetamol, diclofenac, or tramadol. Okay, this is the dermatome, myotome, and osteotome. Next, for all the basic blocks considered, these are the first step you have to do it. First, ASA standard monitors, ECG, BP, pulse oximeter should be there, and you should have anesthesia machine checked and all the AVM equipments ready. Okay, now the skin should be prepared with chlorhexidine with alcohol, and there should be a high frequency linear probe, and with the block needle. Patient position is always supine. Local anesthetic choice depends upon you are giving anesthesia and or it has been used for analgesia. Usually I'll be taking 0.5 bupivacaine with dexamethasone. So 0.5 bupivacaine is like around 20 ml. So the literature says that we can deposit around 15 to 25 ml depending upon the patient's BMI. Okay, and then the local anesthetic can vary from ropivacaine, or you can use lignocaine. I always use a combination of bupivacaine 0.5 plus dexamethasone in case if I require anesthesia. But if the same thing, if I require only for analgesia purpose, I'll use ropivacaine 0.2 plus dexamethasone. Dexamethasone, I use it like around 4 mg if I'm using like around 25 ml of the local anesthesia, and just to prevent the postoperative neuritis. A needle, nerve block unit needle, that is echogenic needle, 10 centimeter needle will be used. So now scanning. Always, in order to do a femoral nerve block, you should keep the patient in the supine position with the leg extended. You are placing the probe parallel to the inguinal ligament, so which is like around 1 to 2 centimeter below. The USG monitor should be opposite to the place where you are doing the scan. For example, this patient is undergoing a right-sided femoral nerve block, so your ultrasound monitor will be in the left side facing opposite. Okay, so first palpate the femoral artery and then place exactly the probe, the linear probe in this direction over the femoral artery, and now you'll see these structures. So the structure which is palpating will be an artery, and if you still have a doubt, you can place a Doppler, and here this will be a femoral artery, and medial to that we'll be having a femoral vein, and lateral to that we have got femoral nerve. So you see here, this is an important image. This is the fascia iliaca. Okay, and this entire structure is not a femoral nerve. Only this portion is the femoral nerve. So it looks like a hyperechoic region with hypoechoic round-like structures, and all these round-like structures are nothing but the nerve fascicles. Okay, and now when you want to, the main aim, what is our main aim while we are giving a femoral nerve block? We have to pierce the fascia iliaca and we have to deposit the drug below the femoral nerve or close to the femoral nerve. Okay, so now usually when you keep a probe, you'll be seeing not two structures like femoral artery and femoral. You'll be having some 3 structures or 4 structures of 4 blood vessels. See, what happens is that when there are multiple vascular structures, basically it will be a division of the femoral nerve or in the femoral vein. So you have to scan cephalad until you get one artery and one vein. So these are nothing but the branches of the femoral vein, femoral artery, that is superficial femoral artery, deep thoracic artery of the thigh, or suprafunda femoral artery, and there will be a femoral vein. Okay, so the next point, so the first thing what I told, you have to, the first thing is you have to palpate the femoral artery, place the probe over the femoral artery and identify the vessels. And if you are seeing more than 2 vessels, you have to scan proximally. Okay, so until there is a single femoral artery. Okay, now if you see this, now here you have got one single femoral artery, one single femoral vein, and the structure is like this. The ultrasound probe position is like this, and this is the point where you get the femoral nerve, which is white. And you see this thick portion is only the femoral one, and these are nothing but the thickened fascia. Okay, so whenever you do a blind block or whenever you do a nerve stimulator guided block, even if your nerve stimulator needle is here, you may elicit quadriceps twitching, but ultrasound guided injection is only going to be giving 100% results, because even if you elicit nerve stitching, some amount of drug will be present in the outside the fascia iliaca, so it may directly not act on the nerve and it is not going to give a complete effect. So the best modality to use the femoral nerve is ultrasound guided. So you have to, now 2 important things, you have to cross the fascia iliaca and make sure that you are going to deposit the drug here. And if you just bring the needle and you keep the needle here, and when you give your drug, the femoral nerve block is not going to happen. Okay, and this big muscle, the big muscle which is present below the femoral nerve is nothing but the iliacus muscle. Okay, now see here, this is the needle and here you have a femoral nerve. So our first point, cross the fascia iliaca and then make sure that you are just beneath to the lateral part of the femoral nerve, and only then you have to give the drug so that it is going to push the nerve towards the artery. Okay, so now once you give local anesthesia, you have to be sure that your local anesthesia is going to track below the femoral artery. See here, we have deposited the local anesthesia here, and this is the femoral artery, and this vascular structures are enclosed by another fascia. Okay, so if it is going to track below the femoral artery, it makes sure that your local anesthetic that you have deposited has crossed fascia iliaca and it is going to engulf the femoral nerve. Okay, so now if you want to place a continuous femoral catheter, you can use a 2-Hoy needle and like 18 gauge 2-Hoy needle, and you can just insert the catheter once we identify the femoral nerve. And once you give local anesthesia, again you have to be sure that the local anesthetic pool is present below the artery. Okay, now see here, this is the just a model example. I palpated the femoral artery, I have placed my linear probe, and I am seeing I'm seeing the image. And then what I have to do, I have to move the, if I'm seeing 2 or 3 more arteries, I have to move the probe cephalad. And now this is the image which I got initially, you can see. And again, the vein should be lateral to the artery. It should not be below. So I'm scanning cephalad. Now here you can see the superficial femoral arteries joining to become one single femoral artery. And this is the point where I have a single artery, a single vein medial to it, the thick and hypoechoic structure. And this is the femoral nerve, especially the lateral portion is the femoral nerve. Now I'm going to demonstrate how I'm going to do this. So I have inserted my needle. You can see my needle very clearly. It is crossed the fascia iliaca and it is present just above the bundle. I have given local anesthesia, and it is, see, the pool of local anesthesia is here. It is not crossing the fascia which is covering the vascular sheath. So I'm going to get a perfect block. So this is the nerve here, and you can see the pool of the local anesthesia which is present above the nerve. And the patient is going, the patient had an excellent relief. This case I did two days before, and the patient had a wonderful relief. So some tips. The most common anatomic structure that may be mistaken for the femoral nerve is an inflamed node. So always get history of two things, whether the patient is having a history of cancer and whether the patient had history of any tuberculosis. Okay. And always apply gentle pressure to the transducer. If you're going to press the transducer tightly, it is going to compress the femoral veins and you cannot get an optimized image. And another most important thing, if you press tightly, because during the initial time of practice, if you press tightly, then you are going to press the interfacial planes, which will interfere with the adequate spread of local anesthesia. And never inject against high pressures. When you are using a pressure manometer, the pressure manometer should always be less than 15 psi, because at this stage, if you are going to inject against high pressure, see, this is everyone will not have an opportunity to get the pressure manometer. So you can just feel it. If you're having some very high resistance in whatever block you give, the block is not going to be successful at all. Because here in this case, mostly this is intrafascicular block. Okay. So like a femoral nerve is like maybe 1 to 2 centimeter, maximum 1 centimeter or 1.5. So when you are going to give 20 ml, all the 20 ml is not going to go and it is not going to be placed over the femoral nerve. So you're just going to place a pool of local anesthesia and it is going to spread in the intrafascicular region. So make sure that you're not injecting against very high pressure and it should go very smoothly. The next thing is circumferential. If this is the femoral nerve, it's not like you have to use local anesthesia to spread over the entire femoral nerve as we do in case of supraclavicular brachial plexus block. Only pool of local anesthetic just adjacent to the lateral portion or superior or inferior to the femoral nerve is more than enough, and you will get an excellent relief for 6 hours or more. And the one more thing, initially we will be using femoral nerve for hip surgeries, but whenever we do hip surgeries, the landmark, and if you are planning post-operatively want to do a femoral nerve block, then actually post-surgery what happens is that there will be a lot of fluid extravasation due to tissue damage, and this can lead to pushing of artery and vein nerve deeper. Okay, and at the same time, if the patient is very obese, always you use tape, white plaster tape, as you can see in this image. Use the tape and ask the help from the assistant, and then fix the abdomen and then go for it. Okay, so that your inguinal crease or inguinal ligament will be easily visible. You can scan the probe cephalad and nothing is going to affect you. Okay, now let's go to the another nerve block, lateral femorocutaneous nerve. This is very important nerve. Only like 2 days before I did a case of meralgia paresthetica. So where there is a compression of lateral femorocutaneous nerve. So the pertinent anatomy is LFCN is formed by the dorsal ramus of L2 and L3, and as they form, they just exit the pelvis below the inguinal ligament. The anatomy of the LFCN is variable. So here in this image, you can see there are 2 branches, but it can go up to 3 branches. So what is our school thought? This LFCN can be blocked by its present 2 centimeter medial and 2 centimeter inferior to anterior superior iliac spine, and is it at the depth of 1 centimeter. So this lateral femoral cutaneous nerve, it is present just below the fascia lata and above the fascia iliaca. Okay. So when you place a probe here, first, what you see here, this is the iliacus muscle where the femoral nerve lies, and now laterally you are moving on. And once you see, there is a triangular shaped muscle, which is nothing but the sartorius. Second important point that you have to remember, triangular shaped muscle, whenever you keep a probe, you will not know where you have placed. But if the muscle is triangle, that is always sartorius. Okay. And now the LFCN is present above the sartorius. Okay. And lateral to sartorius, we have got transverse fascia lata muscle. Okay. So why this is important? Sometimes the nerve will be, the branches of this LFCN can be seen between the sartorius and transverse fascia lata muscle. Okay. So all these three blocks are interconnected. Let me show you how. So initially you are keeping the probe medially, you are palpating the femoral artery and you can see the femoral just parallel to the inguinal ligament. You are just going to move the probe laterally, and once you move the probe, you can see the muscle here which is triangular in shape. I told you any muscle which is triangular shape, that is nothing but sartorius. And just this LFCN, in as per the literature, 70% it is not visible, and 50% of the patients, the LFCN nerve is always associated with the lateral femoral cutaneous artery. You can see the palpation. If not, you can directly pierce the fascia lata, and then you can deposit the drug over the sartorius muscle so that you can see the movement, the facial layer separating between the sartorius muscle, and this we'll discuss in this video. And then the patient will get excellent relief. Another indication is sometimes when the patient is doing a hip surgery, hip replacement surgery, always the surgeon will take a wide lateral incision. At that time, if you just give femoral nerve block, the patient is going to scream out of pain once they come out from spinal anesthesia. And now you have to give lateral femoral cutaneous nerve, and that is going to give an excellent relief, excellent relief. So see here, first initially you are just keeping your probe will be here. Gradually you are sliding laterally, and once you slide laterally, you see a triangular structure. As I told you, it is nothing but sartorius. Okay, and no other muscle is triangle. Okay, and these nerves will be like hypoechoic, and you just deposit, take out the needle, you bring here, give the local anesthetic, and you can just get a good relief. It is not necessary that you have to see the nerve. You will get 100% efficacy, 100% perfect block only if you cross the fascia lata and deposit above the sartorius muscle. Okay, so you can see here, this is just a demo. I just wanted to show you the probe portion. First you palpate the femoral artery and you are keeping the probe how you did femoral nerve block. And once you have done femoral nerve block, what I'm going to do, I'm going to pull the probe laterally. See, this is how I'm going to pull. Okay, now see, I'm going till anterior superior, below anterior superior iliac spine. Okay, this is the point that you have to know. Okay, now see, so initially I have palpated the femoral nerve. I have placed the probe just near the, initially I have palpated the femoral artery and I have placed the probe above it. Now you can see femoral artery here, femoral vein here, and this is the femoral nerve. And I'm going to scan laterally. Okay, I'm scanning laterally. This is the iliacus muscle. And once I go, boom, I just see a triangular shape structure. And what it is, that is nothing but sartorius. Okay. So now I'm just going to scan laterally, and you get this picture. See, not always you'll be able to see tensor fascia lata muscle. Here you can see the membrane, okay, the fascia which is connecting the tensor fascia lata and the sartorius muscle, and this is the fascia lata. So what you have to do, bring your needle, cross it, cross the fascia lata, deposit above the sartorius muscle, boom, you're going to get the perfect block. Okay. So, and one more thing, if the patient is very lean and thin, you will be getting a very small tensor fascia lata. You cannot appreciate it at all. So your important goal is to just place the needle just above the sartorius muscle and give the local anesthetic, and you'll get a perfect relief. And let us see how we are going to do this. Okay. Sorry. See, my needle is exactly over the sartorius. Can you see the movement of the facial planes? So there is a beautiful separation of the facial planes. And I literally didn't see any hyperechoic or hypoechoic fascicles. Okay, so there is wonderful movement of the facial plane. This is the facial lata, and this is the sartorius muscle. It has been very beautifully separated by the pool of local anesthetic. And I used to give like 10 ml of the local anesthesia. Ideally, 5 is enough. And if you're not sure that, if you're not able to visualize the nerves properly, or if it is not associated with the pulsatile artery, then we can directly deposit like 10 ml of local anesthesia. This is as per the literature, and it is going to give a wonderful result. So the nerves, as I told you, can be difficult to visualize due to normal anatomic variation. So if you perform blind blocks, only out of 10% is going to work. Remaining 90%, the drug is not going to deposit it properly. And if the nerves cannot be found with ultrasound, infiltrate local anesthetic in the tissue plates, that is especially on the sartorius and between the sartorius and tensor fascial lata. So if you're infiltrating in two regions, 10 ml over the sartorius and 10 ml between the sartorius and tensor fascial lata muscles. So in this case, I'll be using 20 ml totally. Okay. So next is an adductor canal. It's a selective femoral nerve root block. This is a very important theory exam question, because when I did my MD, I got draw a neat and label diagram of adductor canal anatomy and explain the importance of subsartorius or adductor canal block. So let me go this block in very detail. This is the anatomy of the lower limb. So if you see this right lower limb, you can see one muscle which is crossing from lateral to medial. Okay, and this muscle is called as the sartorius. Okay, just remember this. This muscle is called as the, this muscle is the sartorius, one which is crossing from lateral to medial. And in the leg, we have three muscles. This is rectus femoris, vastus lateralis, vastus medialis, and below the rectus femoris, we have vastus intermedius. So to the point, you have to remember this muscle which is going from lateral to the medial thing is sartorius. And here we have vastus medialis. And over the medial end, we have three muscles, adductor longus, brevis, and magnus. Now, if you see the femoral nerve, once it passes below the inguinal ligament, it is going to break down into saphenous nerve, and it is going to give branch to the vastus medialis. And we have got an obturator nerve, which is the anterior division of the lumbar plexus. Okay. Now, what is adductor canal? This is a very important thing, the diagram. Please remember. I'll made it very simple. So we have got two triangles. One is femoral triangle. Another one is popliteal triangle. Okay. And these two triangles are joined by a canal, which is called as the adductor canal. Now let us see. See, femoral triangle, this adductor canal is going to communicate the femoral triangle with the popliteal triangle. Okay. So now, adductor canal. Here, this canal is like around 6 to 8 centimeter in length. Okay. Now let us see the boundaries. So anterior laterally, what muscle we have? We have vastus medialis, and posterior medially we have adductor longus and adductor magnus. Okay. Now superiorly, see, I have taken out this sartorius muscle. So superiorly, that is anteriorly, anterior portion of the adductor canal is formed by the sartorius muscle. Okay. Now, where this adductor canal starts? It starts where the sartorius muscle crosses over the adductor longus. Okay. This is the sartorius and this is the adductor longus. Okay. And where it is going to end? This is the posterior portion. This ending is formed by the adductor hiatus. Adductor hiatus is nothing but the natural opening which is formed by the adductor magnus muscle. Okay. Now, what are the contents of adductor canal? The femoral artery is going to divide and it is going to give out the branch. Superficial femoral artery will be there, and you have got saphenous nerve and you have got nerve to vastus medialis. Okay. So this is the anatomical dissection. Here you can see the muscle which is going from lateral to medialis, sartorius, and here you can see the artery which is the femoral artery, and here you have see the common femoral nerve, and the branch is going to branch, mainly saphenous nerve is going to enter into the adductor canal. Okay, so you can see the femoral triangle, Apex of the femoral triangle I told, adductor hiatus, and this is the popliteal fossa. Usually the adductor canal is 7 to 10 centimeter, and now the adductor canal, if you see, it is like almost like 12 to 15 centimeter below the inguinal ligament. Okay. Now, why this adductor canal block came and what's its importance? It has got a sensitive innervation to the knee joint. See, initially, whenever the patient undergoes an arthroscopic ligament repair, or whenever there is a knee joint replacement, people will be giving an epidural, and later on it was being changed to femoral. But even though when they gave femoral with ropivacaine 0.2 or 0.4 or whatever it is, they had quadriceps weakness. They were not able to mobilize the patient. And they will get, orthopedic surgeons are advised to do rapid mobilization. That is, they have to do mobilization within 8 hours. Only then they can prevent fibrosis. And physiotherapy started 8 hours. So if there is quadriceps weakness, obviously they cannot mobilize the patient. So now they wanted to do passive stretching 8 hours post-surgery, but the quadricep weakness should not be there. So when they give these blocks, what happens? Almost there is no quadriceps weakness. Let us see the anatomy. So this is the knee joint innervation. The knee joint has 12 nerves, 12 different genicular nerves. The knee joint is supplied by the branches of femoral, obturator, and sciatic nerves. Okay, and basically there are 12 joints. Okay, now whenever we take up a needle and whenever we are going to give a low volume, like let us suppose 10 ml in the adductor canal, the local anesthetic will stay into the canal. And what I told you, I told 2 nerves, especially the saphenous nerve and the nerve to vastus medialis, and this is going to just cause block only two branches out of the 12 branches that we discussed, and it is going to provide anesthesia to the medial leg and to the medial portion of the ankle. So when we give only the saphenous nerve block, it is going to cause only like 10 to 20% of the pain relief. Okay, but when you give high volume like 30 ml, what happens? From the adductor canal, due to the nature and gravity, it is going to go into the popliteal fossa. So now it is going to cause a compartment block, which is going to block saphenous nerve, nerve to vastus medialis, obturator nerve, anterior and posterior branches, and sciatic branches to the posterior capsule of the knee joint. Okay, and all these are sensory innervators to the knee. Okay, and it is not going to go up. It is not going to block the superficial femoral nerve branches. So you are absolutely not going to get any proximal muscle weakness or quadriceps weakness. So after giving a high volume, you see, there is out of 12, 10 nerves have been, 10 genicular nerves of the knee joints have been blocked. And this has been proven by various literatures that you get 90 to 92% of the analgesia, and even the dose of opioids, NSAIDs has also been reduced following popliteal sciatic nerve. So whenever they do any arthroscopic reconstruction surgery, especially posterior cruciate ligament reconstruction, I used to place a catheter in the adductor canal. So just 6 hours post surgery, they will start physiotherapy, and 8 hours exactly they will do mobilization. So this is very important. First, I'll show you the diagram. See here, I palpate the femoral artery, identify the femoral artery like how we did in the first case. So this is the femoral artery, and medial to that we have femoral vein, and this is how we place the probe. Now what you have to do, remember the muscle which is going from lateral to medial is sartorius. Okay, and this sartorius, another important point, it is always triangular. Okay, now when I keep my probe here, I am seeing my femoral artery and femoral vein. This is the femoral nerve. I am not seeing any sartorius. But now, second image, I am slowly going down. Can you see the probe which is slightly, I'm just going down medially. Can you see the probe is just over the sartorius? And here in this ultrasound diagram, you can see that there is a triangular shaped structure. Okay, and this triangular shaped structure is nothing but the beginning of the sartorius muscle. And as I go down, you see the femoral vein has gone down. Okay, now further I go down, you can see another triangle sartorius very prominent. Can you see almost half of the probe is now over the sartorius muscle, and you can see the prominent sartorius. Okay, and below the sartorius, what you have? we have femoral artery. So basically you are tracing the femoral artery from above and you are going caudally, and as you go down caudally, you can see the sartorius muscle. So initially sartorius muscle was lateral to the artery. Now as you go down, the sartorius muscle is just coming over the artery. Now the end point is the point where that the artery is exactly just in the mid portion of the sartorius muscle, just exactly below the mid portion of the sartorius muscle. So here you see as the sartorius muscle, sartorius muscle here, and this is the femoral artery, femoral vein, and here you see the nerves. Okay, this is the saphenous nerve and the nerve to vastus medialis, and we have got a membrane. This membrane, the fascia, exactly. That fascia is called as the so this is the what is it, nerve to vastus medialis, and this is the vastus medialis, and here we have got adductor. So vasoadductor fascia is going to cover the nerves, and ultimately what we have to do, our needle has to pierce the vasoadductor membrane to give local anesthesia in this region. So see here, so this is the artery, this is the femoral vein, and here we have this white color thing is nothing but the fascia connecting the vastus medialis muscle and the adductor magnus muscle. So this is vasoadductor membrane. So when we bring our needle from lateral to medial end, the needle should come like this. It should pierce the vasoadductor membrane, deposit the drug here lateral to the artery, so that these two nerves will be blocked, and the subsartorius plexus that is present below this, the lux are slowly going to diffuse this membrane, and it is going to block the obturator and the sciatic branches of the knee joint. Okay, so this is the pertinent anatomy of the adductor canal block. Okay, now initially we are just scanning from this region for identifying the femoral artery. Trace the femoral artery as you go down, and you see once you reach the mid portion, once the femoral artery exactly in the mid portion of the sartorius muscle, which is nothing but the triangular muscle. Sir, you should not ask that this is not triangle. Actually, the transducer is being applied of so much pressure, that's why it's losing its triangular shape. Okay, so here we have got the sartorius muscle, and this is nothing but the vasoadductor membrane. Pierce the vasoadductor membrane and give the drug, and definitely you're going to get the results. Okay, so can you see here, the needle is being placed wonderfully. It is crossing the vasoadductor membrane, and now you are see this is the vasoadductor membrane, and your needle is being pierced off, and then local anesthesia. Once you deposit, you'll get fantastic result. The joy of the patient will say, sir, I'm not having any pain despite undergoing surgery, and I'm able to mobilize. Only when you perform this block, now you'll get that. Once the patient says, you'll get this joy, and that will be something very great. And this is a very simple block. Initially, when I studied, the anatomy was nothing. I have made it very simple. Please follow this. I'll show you the demonstration. You'll get a lot of happiness. So see here, and once we cross the vasoadductor membrane, you just deposit the local anesthesia, and this local anesthetic always pushes the nerve deep, and it push the artery lateral. So this is a good clinical sign to ensure there is correct local anesthetic spread. Okay, now here I am just showing you. See, first my image is always in the same position. Femoral nerve you'll be doing here. Okay, femoral nerve block. And once palpate the femoral artery, you just place the probe linearly. Now you're just going to scan the probe distally. Okay, let me show in this diagram. You're just scanning the probe distally from cranial to caudal. Okay, so once you scan, what you're basically going to trace, you're going to trace the femoral artery. That's all. You're not, don't identify sartorius, nothing. From above to below, just trace the femoral artery. Okay, so now I'm just going to show. So initially, this is the femoral artery, femoral nerve. Okay, femoral artery, femoral vein, and femoral nerve is here. So I'm just going to move my probe down. Okay, so as I move my probe down, can you see? So I'm just coming here. As I move my probe down, can you see a triangular structure? And this triangular structure, once I follow this femoral artery caudally, then this is going to just jump above because the sartorius muscle is crossing from lateral to medial direction. You can just see here the triangular muscle slowly. This is the triangular muscle sartorius. Slowly it is crossing the femoral artery. And once it reaches the apex of the triangle, I'm going to stop. Can you see? This is a wonderful demonstration. Okay. So again, I'm going to play. You can see the origin of the sartorius. Slowly it is coming above the femoral artery. And once the femoral artery is exactly above the mid portion of the sartorius muscle, I'm just going to stop. That's all. This is the nerve. And you see the nerve is very beautifully seen. And now you just pierce the vasoductor membrane, give the drug, the patient is going to have an excellent relief. And here real-time demonstration of the spread of local anesthesia. So can you see the fascia being spreading out? Okay, exactly. I've caused the vasoductor membrane. The artery is pushed towards the one side. The sartorius is going above. I'm going to create a pool of local anesthetic. And I gave almost 30 ml of local anesthetic. The patient was like having an excellent relief. Excellent relief. No need of epidural, nothing. And with this, it is going to be very cost effective also. And the patient is going to get a very good relief. Especially the orthopedic surgeons will be very happy because this will ensure that they are doing regular physiotherapy without any pain. Okay. So thank you very much. Thank you very much for the opportunity, sir. So I guess I have shown some tips to perform this block.
Thank you, Vishnu. Thank you. Thanks a lot. It's a very nice, wonderful lecture with the demonstration. And I hope it helps the PGs very much to get a good knowledge about the femoral, lateral femoral cutaneous and adductor canal blocks. There are some queries. First one is why dexamethasone in femoral nerve block? Is there any specific reason to add dexamethasone?
Sir, the main reason is, sir, dexamethasone. See, whenever you place a needle, you are going to cause an inflammation. So we are just giving 4 milligram of dexamethasone, and that dexamethasone is going to reduce the post-operative neuritis. See, sometimes as a beginner, you might damage the nerves. Okay, sir. So you might go place your needle near the nerve fascicle so that the vasa nervorum, that is the vessel supplying those things.
Please adjust your camera. Your face is not well seen now.
Okay, sir.
Right from the beginning, it does not well seen.
Right, sir. Right, sir. Sir, just to reduce the post-operative neuritis, we are just giving, sir. And another reason for using dexamethasone is it is going to prolong the duration of the action of the local anesthesia, and this is the cost-effective one when compared to adding adjuvants like dexmedetomidine, clonidine, or whatever it is. So when we use dexamethasone, it is going to be very cost-effective, and just to reduce the inflammation, I'm going to give this, sir.
Okay. What will be your endpoint of femoral nerve stimulation if you do it with ultrasound plus nerve stimulation?
Sir, always whenever we use peripheral nerve stimulator with the ultrasound guidance, whenever we stimulate, we'll be getting quadriceps twitches. But always we have to be sure that the needle is lateral to the nerve. And it should not be medial to the nerve when we are using PNS guided. Because when we go medially, we are unnecessarily, once we give 5 ml, our needle might misplace into the interfacial plane. And once we post an interfacial plane, the drug dose efficacy is reduced. So if you are posting like almost 20 ml, then almost only 5 to 10 ml will reach the effective site. Remaining drug will be in the interfacial plane and you will not get the effect, sir.
Okay. No, I have a lot of queries, but problem is we don't have time to discuss those things.
Sir, definitely,
so
sir.
We'll discuss in person later. If time is there, at the end we'll discuss about this again. The one question from Dr. Partha, sir, is why we have to go for high volume? Like you mentioned some high volume, and I think you mentioned high volume in adductor canal also.
Yes, sir.
Know how much volume you want to give?
Sir, the thing is, sir, if we give like almost 5 to 10 ml, no, sir, then basically the drug is going to stay in the adductor canal only. Okay, only if it is going to go out of adductor canal, you are going to block the subsartorius plexus, which is going to involve the obturator and the sciatic branches of the knee joint. Okay, so whenever you give 30 ml, due to gravity, it is going to go into the popliteal fossa where there is subsartorius plexus. And only when the subsartorius plexus is blocked, out of 12 nerves, 10 nerves are going to get blocked. And it is proven in the literature, it is going to give 92% of the pain relief.
So how much volume do you recommend?
Sir, average is 30, sir. I always use 30, sir.
Okay, 30 ml.
This is as per the literature, sir.
This is for adductor canal block.
Yes, sir. Yes.
So when you go for femoral nerve block, how much volume do you recommend?
Sir, 15 ml is enough, sir.
Okay, do you believe in the concept of 3-in-1 block when you use high volume in femoral nerve block?
Sir, once the lumbosacral plexus came, rather than using 3-in-1 block, I always go for lumbosacral plexus blocks, sir. And yeah, but we have to keep in mind the local anesthetic systemic toxicity. And this is the very important thing that one has to consider when we are giving multiple blocks. 3-in-1 blocks is nothing but the spinal anesthesia of the unilateral leg, where we block femoral, obturator, and the sciatic nerve block. So at that time, what I do is I used to take a mixture of like almost 60 ml, sir. And I used to add 8 mg of dexamethasone, 50 ml, 12 to 15 ml over the femoral nerve, 10 ml over the anterior division of obturator, 10 ml over the posterior division, maybe 15 to 20 ml over the sciatic nerve blocks, for the sciatic nerve blocks.
So you want to go for individual nerve blocks rather than, you want to give it an individual nerve block?
Yes, sir. Yes, sir. Yes, sir.
Okay, thank you, Vishnu. I think some more questions are there. If you are free enough, we will discuss at the end after this, at the end of the session, if we have enough time.
Sir, definitely, sir. Definitely, sir.
Thank you.
Sir,
one point I just want other speakers from Ganga to comment over this at this session is about the dual subsartorial block, which is coming up very recently from the center, Ganga Center. Vinod or Madan, are you here to take up?
Yes, sir.
Dual subsartorial block as an alternative to adductor canal block to get the same effect.
Sir, I didn't understand your question, sir. Can you speak a bit louder, sir? Sorry.
No. Actually, there is a recent presentation about the dual subsartorial block. So you are talking about 30 ml volume at single point injection.
Yes, sir.
There are some recent updates related to at the 2 level, adductor canal block at 2 level, dual subsartorial block. They have termed it as, I think that paper has come from Ganga Medical Center.
Yes, sir.
So I
yes,
just
sir.
wanted either Madan or
Yes, sir. Yes, sir. I have gone through it, sir. Sir, basically, I just wanted to stick to the basics. Okay, sir. So I just wanted to ensure.
I told you, this is just a recent update.
Yes, sir. Yes, sir. Yes, sir.
I think. Madan, you want to add up any point?
Yes, sir. We have been doing this dual subsartorial block for last 1 or 2 years. So initially we were giving adductor canal block only, where we used to give some 25 to 30 ml at single level, mainly the proximal adductor canal. But recently we started doing this. The main rationale behind this block is if we go to the femoral triangle, slightly proximal to the starting of adductor canal, where the nerve to vastus medialis is not covered by the vasoadductor membrane. If you deposit drug in the femoral triangle, that will block the nerve. So because many of the TKRs, the incision will be the medial parapatellar incision. So the muscle and the tendon of vastus medialis will be cut and open. So that will not get covered just by a saphenous nerve block. So if you are giving an adductor canal block alone, only the saphenous nerve and division from the obturator will get blocked, whereas the nerve to vastus medialis remain spared. So that is why we have gone little cranial and started giving a drug in the distal femoral triangle. So that will be the first part of the injection. Second will be in the adductor canal. It will be either in the mid adductor or in the distal adductor. That is mainly to cover the nerves arising from the popliteal plexus, mainly the nerves arising from the sciatic nerve and its divisions.
So if I understand correctly, it is instead of giving 30 ml in single point, you are dividing it into 2 and
2 points. Yes, exactly.
15 ml in the distal.
Yes,
thank you.
Exactly,
thanks a lot. Thanks a lot, Vishnu. And we will move ahead with the second topic. It's again a sciatic nerve block, various approaches. by Dr. Madan Mohan, who is a consultant from Ganga Medical Center Hospital, Coimbatore, who is having more than 6 years of teaching experience, and he had done a postdoctoral fellowship in nerve block this thing. And the center, Ganga Center, is very known for its regional anesthesia. I think we'll get a lot of points from him. Over to you, Madan Mohan.
Thank you, sir. Good morning, all. I first of all thank online PG anesthesia teaching program for this wonderful opportunity. I thank Edward Johnson sir, Jayaprakash sir, and other executive members of the program. So I will discuss about the sciatic nerve blocks, mainly the proximal one. The distal, the popliteal sciatic will be covered by my colleague, Dr. Vinod. So there are various approaches and various named approaches if we take the sciatic nerve block. But as far as the names are concerned, I'm not going to discuss all the names, because if we take the sciatic nerve block, we can block the nerve at 5 different levels. So I'm going to discuss the levels where we are going to block the nerve. So before going into the blocks, I'm going to discuss about the anatomy briefly. So if you take the sciatic nerves, it's a branch arising from the lumbosacral trunk. Okay. So the L4, L5 from the lumbar, as well as from sacral S1 to S3, the anterior rami gives origin to the sacral plexus. Out of that, the sciatic nerve is a major nerve. Okay. So if we take the sciatic nerve, it forms within the pelvis and emerges out of the sacral lateral side of the sacrum, and it leaves the pelvis and comes out of the greater sciatic foramen. After that, it lies in the buttock region. Okay. If we take in the buttock region, the nerve will be lying underneath the piriformis and superficial to the gemelli muscle. Okay. So this will be a potential area to block the nerve. And if you go further distally, the nerve lies between the gluteus maximus and quadratus femoris. This is mainly in the subgluteal region. Again, this is a potential area to block the nerve. If we come further distally, the nerve is going to enter the posterior compartment, and it's going to lie between the biceps femoris and adductor magnus. Biceps femoris will be superficial and adductor magnus deep. Okay. And terminally, it will be dividing into tibial nerve and common peroneal nerve, and they will have further their divisions. So if we take the sciatic nerve block, either using PNS or using ultrasound, we can block at these 5 levels. Okay. So again, I'm going to show the levels where we can block. Coming to the level 1 at the parasacral region. Okay, where we are going to block the nerve at the level of origin. So advantage of doing this is we are going to block the all components of sciatic nerve. Plus we can block the sacral plexus also. Sacral plexus have different nerves, out of which our clinical importance will be the nerve to posterior cutaneous nerve of thigh, which will be supplying the dermatome involving the posterior thigh. Okay, suppose if you are going to do some procedure in the posterior part of the thigh, or if you are going to apply tourniquet in the thigh, this nerve needs to be blocked, or else patient will have some tingling and pain sensation as the tourniquet time passes out. As well as suppose if you are doing some pelvic surgery and you need a potential nerve to get blocked, the sacral plexus is an ideal site to block the nerve. As we move distally, we can block the nerve at the transgluteal level, mainly just underneath the piriformis. Okay, and further distally, we can block it in the subgluteal level, where we'll be blocking the nerve underneath the gluteus maximus and superficial to the piriformis, quadratus femoris. And we can even block the nerve at the mid thigh level, where we can put the drug in the around the nerve underneath the biceps femoris and superficial to the adductor magnus, and then at the popliteal fossa, where we can block the sciatic nerve proper or its division separately. So, and one more thing we need to come across during a sciatic nerve block is there may be some anatomical variants, though they may not be so frequent. There have been some 6 variants which have been identified and published in the literature. If we take the first one, this is the normal one, where the nerve arises and lies underneath the piriformis and exits out underneath the piriformis. Okay. If you go to the other types, here the nerve, if you take the sciatic nerve, as I told earlier, it is a component of 2 individual nerves. One is the tibial and the other one is the common peroneal. It is enclosed in a capsule. This division usually arises at the popliteal fossa, but there may be some anatomical variation where the nerve divides at the level of origin itself, and the nerve comes either above the piriformis like this or within the piriformis like this, and the other division coming underneath that. And sometimes the entire nerve, which is undivided, enters the piriformis and comes out of the piriformis. And other two variants which have been observed are the nerve dividing into two, one coming superiorly and one exiting through the piriformis, and other one just the nerve is undivided and just coming out superficial to the piriformis. So these are the anatomical variations. So that is why some cases, in spite of giving a proper sciatic nerve block at the higher level, there may be some patchy block or sometimes sparing of some component of the femur sciatic nerve. So these things to be kept in mind. But as far as the clinical practice is concerned, we don't much encounter these kind of variants. Majority of the time, you will encounter the sciatic nerve just underlying the underneath the piriformis and exiting the buttock region. So coming to the main thing, why to block sciatic nerve, and second question will be when to block the sciatic nerve, and third will be where to block the sciatic nerve. So why do you want to block the sciatic nerve? So if you take the sciatic nerve block, it supplies majority of the posterior component of the lower limb. As far as the muscles are concerned, the entire muscles of the posterior component, mainly the calf muscles, the hamstring muscles, are supplied by the sciatic nerve, and the dermatomy is covered by the posterior cutaneous nerve of thigh. As we move distally, if you take the leg, the posterior compartment, lateral compartment, and anterior compartment, everything dermatomy is covered by the sciatic nerve branches. Only the medial compartment of the leg or the shin region is covered by the saphenous nerve, which is the branch of femoral nerve. As far as the muscles and osteotoma are concerned, in the leg and the ankle foot, everything is supply of sciatic nerve. So it is the primary nerve which we need to block in order to get a good analgesia as well as anesthesia of the lower limb in the posterior side and entire leg. Okay, so here comes the indication where we need to give a block, sciatic nerve block. So if you take the hip joint, the procedures like total hip replacement or proximal femur fixation, either it may be a DHS or some screwing or even the femur nailing, this will be the ideal block. Okay, and since the hip joint is involved, we have to block the nerve at the level 1, which I have shown earlier. Sometimes even level 2 might also helpful in the hip joint as far as the drug volume is concerned. Coming to the knee procedures like TKR, patella surgery or arthroscopy surgery, any surgery involving the knee joint, we need to block the nerve. Either even proximal is very much useful, but we can come little distal and block at the subgluteal level or even at the mid thigh level. Okay. Then coming to the leg and ankle procedures, we can block the nerve at any level, but popliteal sciatic will be more superficial and easy, and it has a very good success rate compared to a deeper block. So that will be the ideal site to block. And as far as the amputation of lower limb is concerned, we need to devise our block at the level which will be appropriate for the particular level of amputation. Suppose if it is a below knee amputation, you can go for a mid thigh or subgluteal or even popliteal sciatic block. If it is an above knee amputation, you may go for a sacral plexus block or a subgluteal sciatic nerve block. Now, where to block, I have told the levels 1, 2, 3, 4, and 5. Okay, so depending upon the hip joint surgery, we need to block at the sacral plexus. Mainly, we are going to block the sciatic nerve, but hip joint anatomy, if we take, the posterior capsule has innervation from the superior gluteal nerve as well as the nerve to quadratus femoris. We don't have any separate block for that nerve because they are very small nerves and it will be deeply situated. So only thing to block for this is go for a sacral plexus block, which will take care of all the 3 nerves. And for the knee procedures, you can go for sacral plexus or gluteal level or anterior sciatic is also fine. Coming to the leg and ankle procedure, as I said, popliteal sciatic will be more than sufficient to do the surgery as well as for analgesia. Now, there are different techniques available to block the sciatic nerve. We have landmark techniques, we have PNS guided techniques, we have USG, and both, that is the dual technique. So if we take the parasacral, we have Mansour's approach for PNS guided technique. If we take for USG, there have been so many modifications, and what clinically relevant and easy for day-to-day practice will be Taga's approach. And PSPS is a recent, some 4-5 years back, it has been introduced. And lastly, 2-3 years back, PAP block is being introduced, which is the parasacral ischial plane block. So all that four approaches can be useful for blocking the sacral plexus, mainly the sciatic nerve at the level of origin. Coming to the gluteal level, you can make use of PNS as well as USP and dual technique. We have the classic Laborde technique as well as Vinny's modification of the Laborde's technique. These two are the main techniques for blocking the nerve at the gluteal level. If you go subgluteal level, again, so many named procedures are there. Some depending upon the position of the patient, depending upon the approach of the needle, they have named it differently. And coming to the other levels, you can block it laterally, mainly at the level of greater trochanter, and anteriorly also you can block. Suppose the patient is not able to be turned from supine to lateral or prone, we can do it the anterior sciatic nerve block, keeping the patient supine, and popliteal will be the last level which we can block the sciatic nerve proper. Right. So if we take this image, you can see the probe position. If you are doing an ultrasound guided block, the sacral plexus block will be given at the level of origin of the sacral plexus. Okay, this will be the level, and for a subgluteal level, this will be the level where we are going to block the sciatic nerve. Coming to the anterior sciatic nerve block, we will be blocking somewhere here or just closer to the lesser trochanter. This will be the area. Depending upon the place where you can see the nerve clearly, you can block either from here to here, and this will be the level to block the popliteal sciatic nerve. So this is the sacral plexus block. I have just zoomed. So if you see this is the greater sciatic foramen, and from that the sacrosciatic nerve is coming out. Along with that, all the nerves arising from the sacral plexus are emerging out. This is the piriformis, which is the key muscle of the gluteal region. So if you identify this muscle, the nerve will be lying underneath that in most of the patients, unless there is an anatomical variant. And you make use of PNS, pass the needle, go through the piriformis and stimulate the nerve. And then once the evoked response is obtained, we can deposit the drug and get the good sciatic nerve block as well as the other nerves of the sacral plexus. So coming to the named approaches, Mansoor's parasacral approach is being commonly practiced, and it's very easy for us, for even a beginner to do. But you need to keep in mind, because it's a PNS based block, so all the complications pertaining to PNS should be kept in mind. Though we have an end result to get the block success rate, there may be chances of complications, because once the needle is entered the skin, we don't know what all the structure is going through. So there may be chances of injuring any number of structures coming in the path. Usually we are worried about injuring some vessels, and if you go further deeper without idea about the depth, you may enter the pelvis and injure the pelvic organs. Okay, right. So for this approach, the patient should be kept in the lateral decubitus position, and the side to be blocked should be superior, or you can put the patient in prone if possible. Both are well and good, right? So you need to identify the posterior superior iliac spine, palpate the posterior superior iliac spine, and then palpate the ischial tuberosity. Now we draw a line connecting both, and the needle entry point will be 6 centimeters distal to the posterior superior iliac spine. So this will be the needle entry point, and being a deeper block, you need a 10 centimeter or even 15 centimeter stimulating needle, because this muscle itself is bulky as well as fat may be there. So in an adult patient, you may require a longer needle. And you go perpendicular, and you may go and hit a bone. Suppose if you are hitting a bone, it will be the lateral end of the sacrum. Like sacrum is lying like this. This will be the sacral margin. If you are hitting the bone, you may need to just pull out about 1 or 2 centimeters and then just go further lateral, and you don't go beyond 2 to 3 centimeters further hitting the bone. Suppose if you are hitting the bone at 7 centimeters, you may be allowed to go up to 9 centimeters only. If you are going further, say 10 or 11 centimeters, you are going, you may enter the pelvis through the sciatic foramen, and it may injure the vital structures underneath. So this is a simple approach to do a parasacral sciatic nerve block or the sacral plexus block. So once you enter the needle, this is where I told you may hit the lateral border of the sacrum. Okay, so withdraw it and then go further little lateral and you are allowed to go maximum up to 2 centimeters, but you may get the stimulus even within a centimeter also. So once you are close enough to the nerve, you will elicit the response of the sciatic nerve. So we have different different movements of the ankle concerned to the sciatic nerve stimulation. Suppose if it is a tibial nerve component, mainly the gastrocnemius is going to get contracted and you will get a plantar flexion. Suppose if it is a common peroneal component, you are going to get a stimulus from the anterior as well as the lateral compartment, which will cause the dorsiflexion and eversion of the foot. So if you are getting inversion, which will be contributed by both trivial as well as common peroneal component, that will be the ideal one to go ahead. So if you are getting inversion at the appropriate current, suppose if you are doing with PNS alone, you start with the 1.5 milliamp current. Since it's a deeper block, you may even keep 2 milliamps because you may miss if you are wide away from that. If you keep the current more, you can get the track easily. So once you elicit the response and you are happy with the response, you reduce the current and reach up to 0.5. Okay, so deeper block, even 0.6 also acceptable to give the track. Suppose if you are getting the stimulus even at lower current like 0.2 or 0.3, it means that you are entered the plexus itself. So better to withdraw and check again the response is available at 0.4 or 0.5 and it is going off at 0.3 or 0.2. Then you can safely proceed with the drug injection. So second will be the gluteal approach. Gluteal, I will show the video of so this is the video doing the Manjun's approach for parasacral plexus block. So if we take the patient is kept in so if we take so we have marked the ischial tuberosity and we have marked the posterior superior leg spine and we have divided and the 6 centimeter mark has been kept and we started injecting the needle and once you enter initially you will get the gluteus maximus contraction due to the local stimulus of the current. As you move further in interior you will get the foot responses. Okay, here in this case you are getting the dorsiflexion. Okay, as well as now you have started getting the plantar flexion and we are reducing the current, but till 0.4 it is coming now. We are reducing further down at 0.2 it is not there. Right. So we are increase again. Once we get the stimulus at 0.4 or 0.5, we can safely proceed and deposit the drug. Sorry. So coming to the gluteal approach of the sciatic nerve block, here we have two named approaches. One is the Labart's approach and another one is the Vinny's modification of the Labart's approach. So for that, again, position will be the same. Patient will be in lateral decubitus position or even the prone position. You need to identify few bony landmarks. One will be the posterior superior leg spine, and other one will be the greater trochanter, and other one will be the sacral hiatus. Okay. So for Labart's approach, nothing. You just connect GT and PSIS, right? So take a midpoint and come perpendicular 3 centimeters away from this first line, and that will be the needle entry point. Okay. And what Vinny has modified this is he has taken the second line starting from greater trochanter and reaching the sacral hiatus. Right. So he has put an perpendicular starting from the line 1, midpoint of the line 1, which joins the second line. Okay. This will be the needle entry point. So here you make use of the long needle, enter, get the same response, and proceed with the blockade. So prerequisites, if you take any block, you need to keep all the emergency things ready, do the ASA1 standard monitoring. And as far as drugs is concerned, depending upon the indication for what you are doing the block, you may keep your local anesthesia as per that. Suppose if you are doing for anesthesia, you need to give a higher concentration. If you are giving this for analgesia purpose, you can reduce the concentration. And as far as the duration is concerned, you can add some additives to prolong the duration of action. Suppose if you're not confident of doing a catheter, or if you're not planning to do, or if you don't have facility to take care of the post-operative catheter care, then you can go ahead with some single shot block with some additives. And all the proximal sciatic nerve blocks are quite deeper blocks, so it will be very painful and discomfortable for the patient. So you may need to give some shot of some local before pricking, as well as you need to give some adequate sedation prior to putting the needle in. So coming to the USG guided sacral plexus block. So again, the prerequisites for ultrasound guided parasacral blocks is more same to the venous guided block. And for the probe, you need a curvilinear probe. And even with ultrasound, there may be some difficulty in identifying the structures because it is quite deep. If you have a huge patient with a BMI of 30 plus, you will identify the nerve some 10 or even 12 centimeters from the skin. So if you include PNS along with the ultrasound, the chances of getting a proper blockade will be more, and your success rate will be higher compared to single mode, which will be a ultrasound alone or a PNS alone. So coming to the parasacral approach of sciatic nerve blocks, we have TAGAS, PSPS of Benston, as well as PIP block. TAGAS is the one which we are constantly doing in our practice, which will be very easy for us to do. So again, put the patient in lateral position, and you need to keep the probe in front of you. Patient will be in between the monitor and you, and patient is exposed from the gluteal region up to the mid thigh. Okay, and you start putting the probe, keeping the orientation marker lateral or medial, whichever side is you're comfortable with, and just put the probe lateral to the posterior superior leg spine. Identify the posterior superior leg spine. Okay, this will be the posterior superior leg spine. Put the probe lateral to that, and once you keep the probe over that, you will get a straight line formed by the ilium. Okay, this ilium is not going to allow the echoes to pass further down, so you are going to get a straight line. Superficial to that will be the gluteal muscles, mainly the gluteus maximus. As they come down, gluteus medius will also come into the picture. And what you need to do is just move the probe from cranial to the caudal direction till you reach the greater sciatic foramen. How to identify the greater sciatic foramen? Once you come, you will get a discontinuity in the line. Okay, so here you get a continuous line formed by the ilium. Here there is a discontinuity or break in the line, so it will be the greater sciatic foramen. So the moment you get the greater sciatic foramen, you just give a caudal tilt, because all nerves exhibit anisotropy. So only your echoes is 90 degree to the nerve structure, you will get a proper image. So for getting that, you need to give a caudal tilt, because see here, there is no nerve structures lying here. The moment you give a tilt, you are getting the neural elements here. So start from the posterior superior leg spine, you get the straight line, move distally till you get a break in the continuity, which will be the greater sciatic foramen. Give a caudal tilt, identify the plexus lying. So you just come either here or here and deposit the drug. Many a times the inferior gluteal vessels will be accompanied, will be here, and you may need to keep utmost care not to injure the vessels, because it's a deeper block. If you injure, you can't put some compression and hold the bleeding, and it may lead into a hematoma formation. So always make sure that you are doing it appropriately. And if you are not confident, it's better to avoid this block in a patient who is taking blood thinners. So coming to the other approach, which is the Benston's parasacral parallel shift. If we go take the TAGAS approach, we are blocking the nerve mainly in the short axis of the nerve. Nerve is running like this, and we are cutting the nerve like this. If you go to the parasacral PSPS approach, we are going to see the nerve in a long axis. Okay, probe is going to come and lie over here, and the nerve is running in this plane like this. So the end point of both the approaches will be the same. Only thing is, in the initial one, we are seeing the nerve in a short axis. We are here we are going to see the nerve in a long axis. Okay, so how we are going to do this approach? Again, we need to identify the posterior superior leg spine and greater trochanter, and you put a line joining both. Okay, divide the line into two, and you take the medial half of the line. Okay, and you keep the probe between the PSIS and the medial half of the line, and start coming infromedially towards the sacral hiatus. The moment you keep, you will get the again straight line of the ilium. As you keep coming infromedially, you will get the break in the continuity, which will be the greater sciatic foramen. And after the moment you get the discontinuity, you will start seeing the nervous elements. You may need to come little infromedially to get the proper sciatic nerve in a long axis. And as far as the block is concerned, you can come in plane or out of plane, whichever is comfortable. But these blocks are quite deeper. If you are coming in plane, you may need a echogenic needle, because your angle of insertion needle entry will be very steeper. So if you have an echogenic needle, that will be a better one, or else you can straight away go ahead with the out of plane technique. So this is the difference between the Taha's approach and PSPS approach. So here, so this is where we are going to deposit the drug in the parasacral region using the Taha's approach. So we have identified the greater sciatic foramen, and the nerve is lying here. Okay. So this is the needle entering. We are doing out of plane approach. Once you start reach the nerve, you start stimulating at 0.4 current. We are getting the foot response, which is inversion of the foot. So we have accepted that, and we started injecting the drug. So coming to the complications of hiatic nerve block at sacral plexus. So any block, there will be pros and cons. So cons for this block is it leads to blockade of the pelvis flattening nerves, and there may be chances of urinary retention. Though it is a unilateral block, the drug itself may cause the blockade of the nerves, causing the urinary retention in not all patients. Some patients who are having already some issues like prostate hypertrophy and other issues, they may have some complications leading to retention of urine, and you may need to catheterize and do something else to drain out the urine. As far as the this block is concerned, again I have told. So once you are doing only penis gated block, we don't know what are the structure we are going to pierce. So chances of injuring some vessel is a major concern in this block. So I would suggest this block to be done under ultrasound guidance rather than penis if you have the facility. And again, if you are not confident and if you are going in a wrong track more laterally, you may enter the greater sciatic foramen, and further, if you push the needle in, you may enter the columnar rectum, which is the main vital structure lying at that level. So that is also a concern. So we will move on to the distal level, the second level of blocking the sciatic nerve, which is the subgluteal level. So where this block is slightly distal, as well as we are coming distal, the nerve will be coming little superficial. If you take the sacral plexus, the nerve will be the deepest. Okay. If you come to the popliteal fossa, the nerve will be the superficial most. So this block can be done in a safe and easier method. Where we are going to block the nerve is, the nerve lies between the gluteus maximus muscle and the quadratus femoris muscle, and we have two bony landmarks to help us to identify the structure. One will be the ischium lying medial side, and the greater trochanter lying lateral side. So this is the sciatic nerve. So this is where we are going to block. Only disadvantage of this block is the posterior cutaneous nerve of thigh will be spared in this block because it lies far away from this nerve. And if you are going to the sacral plexus block, it will be the posterior cutaneous nerve of thigh will be blocked. But here the nerve is spared, so that should be kept in mind whenever you are doing this block and expecting a dermatomal blockade in the posterior side of the thigh. So how we are going to do penis gated block? Again, we need to identify the greater trochanter and the ischial tuberosity, and just join the both bony landmark, and then you take a 4 centimeter distance from the midpoint of the GT and IT. Okay, and this will be your needle entry point. And this is the routine approach or the approach introduced by Benedetto. If you suppose the patient is not able to turn lateral or prone, you want to do it in a supine position, which was introduced by Dr. Raj. So again, your position, your needle entry will be same, the landmarks are the same. Only thing is patient is lying supine and the hip is flexed and the leg is extended. And you can very well palpate the structures and enter the put the needle inside and stimulate the sciatic nerve. So coming to the USG guided sciatic nerve block, again you need a curvilinear probe. Usually the depth of this nerve at this level will be some 6 or 7 centimeters. The linear probe, it will be very difficult unless if you have a very thin individual or a pediatric patient. You can make use of linear probe. Again, you put the probe, identify the 2 bony landmarks, mainly the greater trochanter and ischial tuberosity, and you keep the probe in between both, okay, and you will get the picture like this. So this is the sciatic nerve, and this is the gluteus maximus muscle, quadratus femoris muscle, and the nerve is lying sandwiched between both. Your needle can come either in plane or out of plane and deposit the drug around the sciatic nerve. So I'll show a video of doing subgluteal sciatic nerve block. So it's not playing. I will, yeah. So this side is lateral and this is medial. Medially you get IT and this is GT, gluteus maximus muscle, quadratus femoris muscle. This is the sciatic nerve. So we are coming from medial to lateral in plane approach, and this is the needle entry, and we are going to just go to the lateralmost end of the sciatic nerve. So after reaching here, you can start depositing the drug safely and cover the entire nerve. So here the nerve is completely covered. Coming to the anterior sciatic nerve. Anterior sciatic nerve is the third level of blocking the sciatic nerve. Only advantage of doing an anterior sciatic nerve is it can be done in a supine patient. Suppose if you have a patient who cannot be turned lateral or prone, this will be the approach of choice. Only disadvantage of doing this anterior sciatic nerve is it's a very deep block. Okay, the nerve will be lying some 8 to 10 centimeters from the skin, so you may end up with a failure block. You may end up with some complications like injuring the vascular structures. So this block is not for all. It's like an advanced block or expert level block. So you need to segregate the patient for anterior sciatic nerve block as per the needs alone. Okay, just like that you can put a anterior sciatic nerve block. But for a pediatric patient, you may even give for anterior sciatic nerve block because the nerve will be very well seen, because the structure will be lying some 3 or 4 centimeters deep only in a pediatric patient up to age of 4 or 5. So you can even go for an anterior sciatic nerve block in that. So where we are exactly blocking is, we are blocking the sciatic nerve at the level of lesser trochanter, and it will be lying between the adductor magnus muscle and the biceps femoris muscle. Okay. The other way of doing is turning the patient. If you are able to turn the patient, you can turn the patient and approach from the posterior side. Okay. So that will be the mid-thigh level posterior approach of the sciatic nerve block. So if you are doing a penis guided anterior sciatic nerve block, you need to identify again few bony landmarks, mainly the antisuperior spine, pubic tubercle, and greater trochanter. So you make a line joining the PT and ascis and divide it into 2. Again, 2 named approaches are there. One is Beck's approach, another one is I don't remember the name. So what they did is, one has divided it into 2 and taken 4 centimeters distal. Another one has divided into 3 parts, and the medial junction of medial 1/3 and lateral 2/3, he has put a line perpendicular which will be parallel to the GT. Okay, so you draw a line between PT and ASAS, and another parallel line to the initial line from GT, and you divide the initial line into 3 parts, and the junction of medial 1/3 and lateral 2/3, you draw a perpendicular joining the second line. So this will be your needle entry point. Right. So you go perpendicular, you may either hit the femur or you may go directly towards the nerve. If you're hitting the femur, just withdraw and go light medial. Okay, and then once you get the appropriate stimulus or endo response, you can go ahead and propose the drug. So only concern for this PNS guided anti-sciatic nerve block is all the major vessels are going to run in this plane. Okay, you may injure the femoral nerve or artery or vein. Okay, if you are going further deep, you may even injure the profunda femur arteries also. Right. USG guided anti-sciatic nerve block. So the needle entry is almost at the same level. You're going to make use of a curvilinear ultrasound probe, and you just keep the probe over the approximate part of the thigh. You just palpate the greater trochanter and keep it slightly medial and down, and you'll get the image like this. So you get the femur here, adductor magnus here, and biceps femoris deep, and the nerve will be lying close to the femur. Okay, this is where you are going to deposit the drug, and you can come in plane or out of plane. But if you are coming in plane, I would suggest to come medial to lateral. If you are coming lateral to medial, you may go and hit the femur. It is difficult for you to come and reach the nerve. So you may need to come more like this, which will be like an out of plane. So I'll show a video of doing anti-sciatic nerve block. So here the patient is supine and thigh is externally rotated. After scanning, you get the femur here. This is the adductors, mainly the adductor magnus lying superficial, and you see the sciatic nerve here, and this will be the biceps femoris, which is the hamstring muscle, and we are coming medial to lateral. So this is the needle entry. You can see the needle very nicely. So once you pierce and go close to the nerve, you can start depositing the drug. So yeah, this is the nerve. Now you can see the drug supplement, drug spreading around the nerve. So as far as the volume is concerned, any sciatic nerve block, you can give minimum of 15 or 20 ml, maximum 25 ml will be sufficient. And if it is a pediatric patient, you need to keep in mind the toxic dose and strategize your volume accordingly. Just for completion sake, I am going to tell the lateral sciatic nerve block, which is not being practiced frequently. It was introduced by Gardini in 1990s, where he put the patient in supine and palpated the greater trochanter and 3 centimeter distal and posteriorly. He marked this needle entry point and went all the way towards the medial side from lateral side. And once you get the stimulus, you can deposit the drug. That's what has been done by him. But due to the very long needle travel, it's not being followed frequently, and I have not given one using this approach. And only issue with this block will be there may be chances of failure because we don't know where exactly we are entering. Suppose if you are pricking and going further down, you may never encounter the nerve, and you will keep on going all the way to the adductor compartment. So chances of failure will be more, and chances of injuring some vital structures will be more. So my take-home messages will be: sciatic nerve can be blocked anywhere, right from the sacral plexus to the terminal nerves at the ankle. Even suppose if you are doing some Greto procedure, you can block individual nerves arising from the tibial and common peroneal nerves. Okay. So you need to devise your block accordingly for the procedure being done. And if you take the ratio of neural to non-neural tissue, suppose if you go to the microanatomy of sciatic nerve, which will be discussed by my colleague, the neural tissues will be more in the proximal region. Suppose if you are blocking the sciatic nerve at the parasacral region, the neural elements will be more compared to the popliteal sciatic and further down. The ratio will be somewhere 2:1 because the connective tissues will be very less in the proximal region. So that is why you get a faster onset of blockade in the proximal level. Also, it adds to more chances of getting the nerve injured. If you are putting the drug inside the nerve, or you are injuring the nerve with the needle, there may be greater complication at the proximal level compared to the distal level, mainly because of the availability of the neural tissues proximally, which is more, and as we move distally, the neural elements will be reduced. And coming to the third point, sciatic nerve block is a relatively longer duration block compared to the other nerves. So we need to keep in mind while devising our drug regimen, as well as adding any additive. This one concern which we follow in our hospital is suppose the patient is prone to get a compartment syndrome of the leg, we tend to avoid the sciatic nerve block, or if at all we are going to give, we give a low concentration without additive, because this may mask the harmful effects arising from the compartment syndrome, and the patient will be taken up in a later situation where the compartment pressure is severe, and we may need to end up with a severe gangrene of the limb and nerves. So last is proximal blockade of the sciatic nerve warrants dual technique. So as I said earlier, it's a deeper block. I would suggest to go with PNS, though if you are confident with USG, to improve the success rate and to avoid complications. And caution to be kept in mind, if the patient, suppose you are getting a patient and you don't know about the coagulation status of the patient, it's better to avoid the proximal blocks, and if possible, you can go to the distal blocks. Thank you.
Thank you, Dr. Madan, for the wonderful lecture and the excellent presentation about various approaches of the sciatic nerve block. I have some queries related to that volume. So you mentioned about the neural tissue, non-neural tissue ratio, proximal versus distal sciatic nerve block. Is there any change in the volume when you go more proximal? For example, you told that volume will be 15 to 25 ml per sciatic nerve block.
Yes,
so will you alter your volume when you go more proximal rather than?
Sir, if you are doing it in a parasacral region, minimum 15 ml will be sufficient. Sir. If you are seeing a good coverage of the plexus, if you are doing it under ultrasound, maximum 20 ml. More than 20 ml will never be required if you are placing it appropriately. But if you come to the distal, like popliteal sciatic, sometimes you may get adequate blockade with the 25 ml or even sometimes 30 ml. Like it depends upon the individual skill and placing the needle. Sir. So I prefer 20 ml for a popliteal sciatic or 15 ml for a parasacral sciatic nerve block.
You mentioned
and you can see the immediate onset in a parasacral region. It takes some 10 to 15 minutes. Whereas if you go to the popliteal sciatic, it may take another 10 or 15 minutes further. So it may take 30 minutes to get up adequate anesthesia of the limb.
You mentioned about sciatic nerve block for patellar procedures. So what type of patellar procedures will mean sciatic nerve block? So
patellar surgery, we can do it only under femoral nerve block because it's purely an anterior compartment. Only thing is, if you're going to apply a tourniquet, because without tourniquet, it's difficult to do a patellar surgery by many of the surgeons. So for that purpose, you can give a sciatic nerve block. And this is going to be just for the procedure alone. You just give some low concentration lignocaine, even 1% lignocaine will be sufficient enough. We don't want that prolonged action. So that for the intra purpose only, we are going to do that.
So you mentioned about one thing like PIP block. Is it sciatic nerve block or something else? PIP.
What block, sir? PIP. PIP is parasacral ischial plane block, sir. I'll show again. So suppose if you are not able to identify the neural elements in a parasacral region, you just go and hit the ischium and deposit the drug. So the drug will seep and cover the.
So it will be more of interfacial plane block rather than
yes, sir, yes, sir.
Pure sciatic.
Right. So this is the same endpoint for all the three blocks which I have discussed. So this is the ischium. Suppose if you don't identify the neural elements here, you just come over.
To share your, Madan, you have to share your screen.
Yeah. So this will be the endpoint for all the three blocks given around the parasacral region. So here is the ischium, sir. If you don't identify, if you are not able to identify the neural elements here, all you need to do is just come and hit the ischium and deposit the drug. It will seep around and cover the sacral plexus.
Yes, thank you. Till now, there are no much queries other than this, Madan. I think
once it comes, we can discuss it.
Okay. Shall we move ahead with the session 3, the last session about popliteal sciatic nerve block, which is a very commonly practiced nerve block, and we should know in and out of this block because we are getting a lot of high risk patients, especially with diabetic foot and multiple comorbid patients, and the solution will be a popliteal sciatic nerve block. So that will be dealt by Dr. Vinod Kumar, consultant, Ganga, from Ganga Hospital, Coimbatore. Over to you, Dr. Vinod.
Yeah, am I audible, sir?
Yeah, you are audible.
Yeah, a very good morning to one and all present here. First of all, I would like to express my sincere gratitude and thanks to Dr. Edward Johnson, sir, and the entire team of Online Anesthesia, the postgraduate teaching platform, for giving me this opportunity to speak on popliteal sciatic nerve block. This is where I work, and it's a 650-bedded tertiary care center dealing with trauma, orthopedics, spine, plastic surgery, and hand and reconstructive unit. We have almost 40 operating theaters, nearly doing about 125 cases per day. And this is our team of anesthesia. We have almost around 70 anesthetists in our hospital. Popliteal sciatic nerve block is used to provide analgesia or anesthesia of the lower extremity below the knee. The important point to be noted here is the area covered by the saphenous nerve is paired here. So for that, the area covered by the saphenous nerve is the medial aspect of the knee and the calf. This area is usually spared here, and it has to be separately blocked by a adductor canal block or femoral nerve block. In adductor canal, it can selectively block the saphenous nerve. So along with the adductor canal block, and it can provide a complete anesthesia below the knee joint. In our institute, this popliteal sciatic nerve block is commonly given for these following indications like ankle fracture, either tension band wiring or plating, bimalleolar ankle, trimalleolar ankle fractures, toe reconstructions, Achilles tendon repair, most commonly given, and bunionectomy and below knee amputation, along with the femoral or saphenous nerve block, and debridement of foot and leg below the knee, like all diabetic foot having debridements. In these patients, I think it is sometimes life-saving, as these debridement patients, they will be in sepsis or they will be in low EF, multiple comorbidities, and having they'll be on anticoagulation also. So this popliteal sciatic nerve block will avoid all the respiratory and hemodynamic. It avoid all the respiratory and hemodynamic effects of general anesthesia. And in these kind of patients, you can't afford for a spinal anesthetic also, because they will be on anticoagulation. Since the popliteal sciatic nerve block is a very like superficial distal peripheral nerve block, even if the patient is on anticoagulant, it is not going to present with a problem. We have been doing routinely a lot of cases with even with anticoagulation, we will be giving popliteal sciatic nerve block. Coming on to the contraindications, absolute contraindications are patient not consenting, allergy to local anesthetics, and infection at the site of injection. Others are all relative contraindications only, like coagulopathy or pre-existing neuropathy. In such cases, like look for the risk-benefit ratio, explain to the patient and the relatives, document everything, and before proceeding with the block. Coming on to the functional anatomy, as discussed by Madan, the sciatic nerve is the largest branch of the sacral plexus, having a root value of L4, L5, S1, S2, S3, and it is 2 centimeter in diameter and 45 centimeter in length. It exits the pelvis through the greater sciatic notch, and it descends into the posterior compartment of the thigh. And in the thigh, it descends between the greater trochanter and the ischial tuberosity, where it gives numerous articular branches to the hip joint and knee joint. And at the level of distal 1/3 of the femur, it diverges into tibial nerve and the common peroneal nerve. The tibial nerve supplies most of the dermatome and myotome and osteotome below the knee joint. Coming on to the popliteal fossa, anatomy of popliteal fossa, it's a diamond-shaped space lies posterior to the knee joint. The boundaries are superolaterally by biceps femoris and superomedially by tendon of semitendinosus and semimembranosus, and inferiorly by gastrocnemius muscle. The sciatic nerve divides into its terminal branches at a variable distance from popliteal crease. As discussed by Dr. Madan, it can even diverge from its origin. From the origin, it can run as a separate nerve, or anywhere just distal, just proximal to the popliteal crease. Coming on to the microanatomy of sciatic nerve, this is one of the important point to be noted in popliteal sciatic region.
As you can see here, the popliteal sciatic region, it has two compartments. One is the subepimysial perineural compartment and the other is the subparaneural compartment. As you can see in this picture, this is the green line. This is the paraneurium. This is a paraneural sheath. The sciatic nerve, it has two components, tibial nerve and the common peroneal nerve. These two are not functionally attached actually. These two are enclosed in a common paraneural sheath. Okay, as it is shown here. And epimysium is nothing but all the muscles are enclosed with the epimysium. The outer layer of the muscle is called the epimysium. So this is your epimysium. This white line is the epimysium. So below the epimysium and between the epimysium and the paraneurium is your subepimysial perineural compartment. And the green line you can see here. So under the green line, this yellow, it is called as the paraneural compartment, subparaneural compartment. So our area of interest is the subparaneural compartment, that is between the paraneurium and the epineurium of the nerve, this nerve. Okay. So our area of interest or the sweet spot of the nerve or the local anesthetic, destination of local anesthetic is to be in the subparaneural compartment. Your needle tip has to pierce the paraneural sheath and the local anesthetic has to be injected inside the paraneural sheath. That is a subparaneural compartment. As you can see here, there is a Cocu septum or Compton cuvillier septum. It is the another connective tissue joining from the anterior paraneural sheath to the posterior paraneural sheath. So this Cocu septum can be an hindrance for drug spread from one compartment to the another. If that is the case, you have to realign the needle so that the local anesthetic is encircled in both the components of the nerve. Before going into the various block techniques, it is very important to know the osteotome, dermatome, myotome, and osteotome of the sciatic nerve of the surgical area to give like incision congruent regional anesthesia or procedure specific analgesia. As I already told, the saphenous nerve area is spared and remaining area is supplied by the sciatic nerve. This is a dermatome, and the myotome, almost all the muscles below the knee joint is supplied by sciatic nerve, both tibial and common peroneal, and this is osteotome supply. This medial side of this knee joint is supplied by your nerve to vastus medialis and saphenous nerve, and again this part in medial malleus, it is supplied by saphenous nerve. Again, this is the dermatome, and this is osteotomal supply. And the tibial nerve divides into the medial plantar and lateral plantar nerve, and this is the anterior leg. Again, as I told, saphenous nerve, and this is a common peroneal in the lateral component. And in the dorsal foot, deep peroneal nerve and the tibial nerve. Again, the plantar foot, sural nerve and the tibial nerve. Coming on to the PNS guided popliteal fossa block, it is further divided into posterior approach and lateral approach. The approach is meant by the direction of the needle. Posterior approach means the needle is going from posterior to the anterior direction, whereas lateral approach is needle is going from lateral to medial direction. Further, in posterior approach, either conventional that can be done in either prone or lateral position, or Raj technique that can be done in supine position. And in lateral, it is called as low cost lateral approach that can be done in supine position. Let us see one by one. The posterior approach is otherwise called as the intertendinous approach. Okay. So the landmarks for the posterior approach are, this is the tendon of the semimembranosus and semitendinosus. You can even draw the tendon like this with a skin marker pen. Semimembranosus and semitendinosus, and then this is the tendon of biceps femoris on the lateral side. And this is the popliteal crease. You have to mark the popliteal crease. And this is the midpoint between the biceps and the semitendinosus tendon in the popliteal crease. And then this is the needle entry point. It is around 7 to 9 centimeters from this midpoint. And it also comes like the midpoint of this tendon. These tendons never meet in the popliteal region actually. It goes like this, and this one goes like this. So it is almost in the midpoint between these two tendons. So this causes the intertendinous approach. In almost 2/3 of the patients, this will be the needle entry point from the midpoint between these two tendons. In another 1/3 of the patients, the needle entry point will be just 1 centimeter lateral to this point. So in some patients, like your sciatic nerve will be situated more laterally towards very near to the biceps femoris tendon. So The posterior approach can be done in either prone position, lateral position, or supine position. You can see the landmarks. This is the biceps femoris. This is the biceps femoris and the semitendinosus, and the membranosus muscle, and the needle entry point 7 to 9 centimeters from the popliteal crease. And this is a Raj approach, or a Raj supine or lithotomy approach. Here, one assistant is needed to hold the leg with the hip flexed and the knee joint extended. The landmarks are the same. This can be used in patients who cannot be turned prone or lateral because of multiple other injuries, polytrauma, or mechanically ventilated patients, or very obese patients and all. Coming on to the preparation for the block, as like any other peripheral nerve block, routine regional anesthesia preparation has to be done, like informed consent, IV access monitoring, last gate aseptic technique, and anxiolysis as needed. Coming on to the requirements, you need a peripheral nerve stimulator with the initial setting of 1.2 milliampere to 1.5 milliampere current, and a frequency of 2 Hz, and a pulse width of 0.1 millisecond. And needle, we use a 22 gauge, 50 to 100 millimeter needle, short bevel insulated stimulating nerve block needle, 50 to 100 millimeter depending upon the build of the patient. And coming on to the local anesthetic, you can use whichever is available in your institution, and either lignocaine, levobupivacaine, or bupivacaine, or ropivacaine, and with or without adjuvants. In our institute, we use perineural dexamethasone 8 milligram, and concentration depends on whether you are giving for sole surgical anesthesia or analgesia. For anesthesia, we used to give a higher concentration, like 0.5% bupivacaine or 0.75% ropivacaine. And for analgesia, it is either 0.2% ropivacaine or 0.25% bupivacaine. And volume, since it is a peripheral nerve stimulator guided block, you need little higher volume, at least 25 to at least 30-40 ml drug is needed. Coming on to the procedure of PNS guided, under all aseptic precautions, the skin wheel is raised with local anesthetic. A 22 gauge 50 to 80 millimeter short bevel insulated stimulating nerve block needle is used. It is at the needle entry point. It is gone perpendicular to the skin, and the target response is looked for. The foot response, either inversion or plantar flexion of the foot at current between 0.3 to 0.5 milliampere is the desired response. Total volume is, as I told, it is 30 to 40 ml. The twitches of the foot or toes, inversion is the most favored response among these 4 responses, and eversion is the least favored response. Why is it so? Means actually, for this you have to understand, you have to know what are the muscles causing inversion. As you can see here, this inversion is caused by tibialis posterior and tibialis anterior. Tibialis anterior is supplied by the deep peroneal nerve, which is a branch of common peroneal nerve, and tibialis posterior is supplied by the tibial nerve. So, since if suppose you are doing a PNS guided popliteal sciatic block and you are getting an inversion response, that means your needle tip is exactly in the center location between these 2 components of the nerve. So this will increase the chance of success, increase the rapid onset of action, and prolonged duration of block. Similarly, why eversion is least favored response means eversion is caused by muscles peroneus longus and peroneus brevis. So these 2 muscles are supplied by superficial peroneal nerve. That is one of the branch of common peroneal nerve. So only peroneal nerve stimulation is not acceptable. It is a least favored response. So you should get both the response of tibial nerve and the common peroneal nerve. That is, inversion is the best response. Next is plantar flexion, next is dorsiflexion, and then eversion. So as you can see here, the inversion of foot is by tibial nerve and the deep peroneal nerve. Eversion of foot is by superficial peroneal nerve, and plantar flexion of foot you'll get after stimulating the posterior tibial nerve, and dorsiflexion of the foot by deep peroneal nerve. This is the foot response you can see here. This is a plantar flexion. Suppose if the patient is in below knee cast or slab and all, in that case you cannot elicit an inversion response. In that case, the response like the following response, the response like this plantar flexion is acceptable. This is a video of popliteal sciatic PNS guided. The patient is in lateral position, and the landmarks marked from the popliteal crease. This is a biceps femoris tendon. As I told, the nerves usually lies very close to the biceps femoris, and the needle is entered perpendicular, and you can see the plantar flexion here. The desired foot response. Since this patient is in POP cast, you cannot invert. You cannot avert inversion response. You cannot elicit an inversion response. The initial current was at 0.6, and now it is reduced to 0.4. Still, you can getting a mild response. You can accept it, and after injecting local anesthetic, you can see the loss of the foot response. This is called positive Raj sign. Troubleshoot while doing this block. Suppose if you are getting local twitch of the muscle, either of semi-tendinosus or semi-membranosus or of biceps femoris, that means you are either too medial or too lateral. So if that is the case, if you are getting local twitch of the muscles, just withdraw the needle and redirect accordingly. If you are getting twitch of semi-membranosus, semi-tendinosus, that means your needle is too medial. And if you are getting twitch of biceps femoris, that means your needle is too lateral. So withdraw the needle and redirect accordingly. Suppose if you are getting twitch of the calf muscles, this is because of the smaller muscular branches arising from the sciatic nerve to the gastrocnemius and the calf muscles and all. So these small muscular branches are actually outside the paraneural sheath. These lie outside the paraneural sheath. So if you're getting these responses, disregard these responses and push your needle further inside to pop the paraneural sheath. So once you pierce the paraneural sheath, you will get a visual cue, and you can get a pop and a facial click also. So apart from the PNS, along with the conjunction with the peripheral nerve stimulator, that 0.2 to 0.5 you get the stimulation. The facial click and the pop also will help you to understand, help you to know where the needle tip is. And then if you are getting a vascular puncture or blood in the needle, that means your needle tip is too deep and too medial. Again, withdraw the needle and redirect accordingly. And again, bone contact. If you are if the needle tip is too deep, can get a contact to the bone. So redirect the needle accordingly. Coming on to the lateral popliteal approach. Position of the patient here is supine. So it is one of the this is called low cost approach, low cost technique of lateral popliteal approach. One of the main advantages, like no need to change the position of the patient to prone or lateral. The foot on the side to be blocked should be positioned so that even the slightest movement on the foot or toe can be easily observed. This is best achieved by placing the foot on a footrest, as like shown in this picture. The landmarks marked by the popliteal crease, and then there's a vastus lateralis tendon, and there's a biceps femoris tendon. Needle insertion site is marked in the groove between the vastus lateralis and the biceps femoris muscle, 8 cm proximal to the popliteal crease, somewhere here. Okay. So technique is under all aseptic precautions. A wheel of local anesthetic is raised, and 10 cm 22 gauge needle is inserted in a horizontal plane between vastus lateralis and biceps femoris, and advance to contact the femur. Contacting the femur is very important to identify the angle of needle. So initially you have to go and hit the femur. After hitting the femur, redirect the needle 30 degrees posterior. You are hitting the femur and redirect the needle 30 degrees posterior to the femur at an angle which femur was contacted, and advance to the nerve. So, and another point is, like, once after hitting the femur, you just measure the length of the needle which has gone inside, and from that, for getting the nerve, usually it will get it in 2 centimeters. So for these two points, you should the important is you should hit the femur first. Yeah, this is a popliteal block lateral approach. You can see here the landmarks on the needle entry point. Coming on to the USG guided popliteal sciatic nerve block. First of all, we'll know about the relationship of vessels and nerves in the popliteal fossa. So imagine this is a popliteal fossa, and in the proximal, the upper part of the fossa, the relationship of the neurovascular bundle is from medial to lateral, it will be artery, vein, and then the nerve. In the middle part of the fossa, from behind forward, it will be the nerve, vein, and the artery. Again, in the lower part of the fossa, from medial to lateral, it will be nerve, vein, and the artery. So actually, the artery is crossing from the medial to the lateral. So this is very important to know, and this you can observe in zone anatomy also. Now coming on to the microanatomy of sciatic nerve, as I told, this is very important to know in popliteal sciatic region. Both the components tibial nerve and common peroneal nerve are enclosed in a common paraneural sheath, the connective tissue. Here you can see this green region is the paraneural sheath. And this is the epimysium of the muscle, and this is subepimysial perineural compartment, as you can see here. And then this is the subparaneural compartment inside this. And then the epineurium of the muscle, and then perineurium and the endoneurium. So our area of interest is this one, in the between the center point between the common peroneal and the tibial nerve in the paraneural sheath, subparaneural compartment. Again, the cross section, you can see the paraneural sheath, the green layer, and inside this is the subparaneural compartment. With high resolution ultrasound, we can visualize this in ultrasound also. This white thick hyperechoic line, you can see this is the epimysium of the muscle. This is the muscle. This is the epimysium, and under this epimysium will be a subepimysial perineural compartment here. And then this arrowhead is the paraneural sheath, and inside this is the subparaneural compartment. So it's marked here, subparaneural compartment. This is our area of interest. Local anesthetic has to be deposited inside the paraneural sheath in the subparaneural compartment. And you can see the nerve fascicles also on the common peroneal nerve. And while giving block, we should not breach the epineurium of the muscle. The epineurium of the muscle should be intact, so our drug deposition should be between the paraneural sheath and the epineurium in the subparaneural compartment. Preparation of the block, as like any other block, apart from routine preparation, specific for popliteal sciatic nerve block is your high frequency linear transducer, 6 to 13 megahertz, and needle length, again 50 to 100 millimeter needle, depending upon the build of the patient and whether you are doing in plane approach or out of plane approach. In plane approach, you need a little longer length of the needle, whereas in out of plane, since the sciatic nerve is almost in the popliteal region, it is just underneath the adipose tissue. So you need a little shorter length of needle sufficient. And injected volume in ultrasound, again, you can use up to 20 ml is sufficient. We used to give always 20 ml of local anesthetic since it is ultrasound guided. And injected type in our institution, we use 1:1 mixture of 20 ml of 2% lignocaine with adrenaline and 20 ml of 0.5% bupivacaine and 10 ml of saline for surgical anesthesia. And if it is a case of perioperative analgesia, we use 0.25% bupivacaine or 0.2% ropivacaine, 20 ml, with or without intravenous or perineural dexamethasone 8 mg. Patient can be positioned in any one of the ways, either prone, lateral, or supine. Prone position offers the best ergonomics for the operator, but the problem with the prone is like some patients, very obese or sick patients, cannot be turned prone. The attractive alternative for this is the lateral position, is most suitable alternative for both patient and the operator. And another position is supine. Again, it is the one assistance is needed to hold the leg flexed and support the leg. And it is always better to extend the knee wherever possible for better visualization of the sciatic nerve. This is a picture showing a probe placement for prone position in the popliteal crease. You can see here. This is a probe placement for lateral position. You can see the patient is positioned lateral with a pillow in between the two legs, and then the probe position in the popliteal crease, and you can start scanning. And this is a probe placement for supine. As you can see here, one assistant is holding the leg, the hip flexed at 90 degrees, and the knee also flexed, and it is holding. And this is ergonomics wise, it is like my least preferred position, because it is against gravity. You have to hold the ultrasound transducer, you have to give adequate pressure, and technically it is a little difficult and you need more expertise. And this is the ergonomics in lateral position. As you can see here, this is the anesthetist, the transducer, patient, and the ultrasound machine. Everything should be in a straight line for better ergonomics in lateral position. And this is ergonomics in supine position. Similarly, all are in straight line. Here you can see the foot is like in a foot rest with the hip joint flexed and knee joint flexed for a supine approach. And in supine, you can give only the lateral in plane approach. It is very difficult to go out of plane in this approach. Coming on to the scanning phase, whatever be the position of the patient, always start scan from the popliteal crease. It is vital to start from the popliteal crease because of 2 points. One is the artery and nerve are more superficial at the popliteal crease. And the other point is like at the popliteal crease, your sciatic nerve will always be divided into its 2 components, tibial and common peroneal. And next point is to look for the pulsation of the popliteal artery. This can be obtained if you much appreciated if you hold the probe still, and you can even confirm with the color Doppler for the pulsation of the popliteal artery. And then the third point is to identify the tibial nerve. Tibial nerve usually lies superficial or posterior to the popliteal artery, and a slight tilt of the transducer usually towards the foot is always necessary to avoid or to minimize the anisotropy. As you can see here, this sciatic nerve will be in the popliteal region. It is not always lying straight and all. It will be some like oblique like this. It will be oblique like this. Suppose if your ultrasound beam, if you're suppose you're keeping the ultrasound like this, ultrasound transducer like this. Sorry. So your ultrasound beam will come and hit here, and it will, the reflected beam will be going away from this. So to avoid this, you have to give a tilt of the probe away from this, like to tilt towards the foot, so that your ultrasound beam will be hitting like this, and you're reflecting back. So just to avoid, minimize the anisotropy. Anisotropy is nothing but the alteration in the echogenicity of a structure in relation to the angle of inclination of the probe. So this is a sonoanatomy at the level of popliteal crease. So if you keep the probe in a transverse orientation in the popliteal crease with the orientation marker facing laterally, so the structure immediately what you will visualize is a popliteal artery, and this is a popliteal artery, and then this is a popliteal vein. If you relax the probe, you will find the popliteal vein, and this is a tibial nerve. This is a thick hyperechoic characteristic appearance of honeycomb appearance of a peripheral nerve. This is a tibial nerve, and on the lateral side, the muscles are the biceps femoris, short head and long head of the biceps femoris. On the medial side, semitendinosus muscle and the semimembranosus muscle. So since my orientation marker is lateral in a transverse orientation, so this will be lateral, this is medial. And below, deeper, you will get the femur. This thick hyperechoic line is the femur, and followed by its acoustic shadow. So this anechoic shadow is because of the femur bone. So this is the starting point for all questions. This is the first image you'll get once you keep the probe in the popliteal crease. The next step is to, so since we have identified the tibial nerve, that is superficial to the, as you can see here, this is tibial nerve will be superficial and anterior to the, sorry, superficial and posterior to the popliteal artery. Since we are scanning in a prone position, so this will be posterior and this will be anterior. As I told, in the middle part of the middle part of the fossa, the arrangement from behind forward will be your nerve, vein, and the artery. Next point is to identify the common peroneal nerve. For this, the probe has to be slide little laterally and moved proximally. So this moves tibial nerve to one side of screen and brings area of common peroneal nerve into view, and sweep the transducer in a proximal distal direction. So while scanning proximally, the common peroneal nerve swoops and in and down to merge with the tibial nerve. And during distal scanning, the common peroneal nerve again swoops up and away towards the superficial tissues around the fibula. This is shown in this video. Start scanning from the popliteal crease. You can see the femur, popliteal artery, and the tibial nerve. You can see the common peroneal nerve coming from the lateral end here. And it is almost joined with the tibial nerve. Yeah, can you see now? Again, I'm moving my probe in a to and fro motion. You can see common peroneal nerve coming and joining to the tibial nerve. Yeah. I hope everybody is able to appreciate it. So this is the tibial nerve, the tibial nerve and common peroneal nerve. So play it once again. Femur, popliteal artery, popliteal vein, tibial nerve. Yeah, you can see the common peroneal nerve coming and joining. So this is the paraneural sheath covering the sciatic nerve. Yeah, this is a schematic representation of the tibial nerve and the common peroneal nerve. So this will be lateral, this will be medial. And this paraneural sheath is called as the Bloca sheath. Next step is to identify an injection point at bifurcation of the sciatic nerve. So this is our area of interest. This point is the injection point at the bifurcation of the sciatic nerve into common peroneal and the tibial nerve. You can see the paraneural sheath. So this sciatic nerve sheath is compact or analogous with the pants, with the legs representing the two divisions, tibial and common peroneal, and the trouser representing the main sciatic trunk. And it is always better to give the block at the level of the bifurcation, this level, rather than giving in the main sciatic trunk or giving distally after a division. So, why? Because it's like at the level of bifurcation, you can see here, this is a paraneural sheath, and there is a connective tissue separation between these two components of the nerve. So that is our target. So this will decrease the chance of nerve injury. And on giving at the level of bifurcation, your drug spreads both to the main sciatic trunk and to the individual nerves also. You can both cephalocaudal drug spread, you can observe. Whereas if you give the block here, there is not enough space between these two tibial and common peroneal components. So on entering the needle, you will tend to injure the nerve, or you will tend to go through and through the epineurium, or you will breach the epineurium of the nerve. Whereas here it is way apart, so you have to block it individually if you want. So it is also not ideal. So ideal thing is to block it at the level of bifurcation without breaching the epineurium of the nerve. So this is the connective tissue in the, inside the paraneural sheath. So my point is like you have to give the block when the nerves are close to each other but not touching. So there should be some space for your needle to enter. So this is like almost close to each other and touching. So here it is close to each other but not quite touching. So that is the end point. That is the end point of the needle. Next step is to plan needle trajectory and approach. Either you can go for out of plane approach, as you can see here. So out of plane is the shortest distance to the nerve. As I told, mostly only the adipose tissue and the sciatic nerve in the popliteal region is very superficial. And in plane, many people will prefer for needle tip and needle shaft visibility. As you can see here, you can clearly see the needle shaft and the tip and the sciatic nerve. Coming on to the needling and injection phase, appropriate trajectory for orientation of tibial nerve and common peroneal nerve. After obtaining that, advance to pierce the paraneural sheath. Aim needle tip at the safe zone between tibial nerve and the common peroneal nerve, or otherwise it is called as a sweet spot of the nerve. As I told you, this is called as the sweet spot of the nerve. And tactile or visual cues and hydrodissection with 0.5 milliliters of local anesthetic will help to identify where is your needle tip. And last point is to assess and recognize appropriate spread of local anesthetic. So after giving the block, you should scan proximal to distal like to exclude the nerve expansion. If the nerve is expanded, that means you are breached epineurium, or it might cause a nerve injury. So nerve expansion should not be there. The local anesthetic should be spread around the two components and assess for adequate spread both like proximal and distal. And repositioning is usually not required if the needle tip is within the sheath. Within the sheath, in between the two components in the paraneural, inside the paraneural sheath, usually the needle reposition is not required. Once again, just recalling the scanning phase, just start the skin crease, look for pulsation of popliteal artery, identify tibial nerve, then identify the common peroneal nerve by sliding the probe little lateral and proximal, and identify an injection point at bifurcation of the sciatic nerve, plan needle trajectory and approach, and assess and recognize appropriate spread of local anesthetic. This is a needle entry picture showing needle entry in lateral in plane approach. Patient is in lateral position, and in plane, this distance will be the distance from the skin to the sciatic nerve. In the ultrasound, suppose if you are in the ultrasound image, I'll show you. Suppose this is the skin and the sciatic nerve somewhere here. So this distance is somewhat 2 to 3 centimeters. So prick 2 to 3 centimeters away from this pointer, so that your needle enters directly from here. So this will lead on to better needle visualization, as all the echoes from the needle will reflect into the ultrasound transducer. Suppose if you are coming from here, you have to go with an acute angulation. So with that angulation, your needle tip visualization, needle shaft tip visualization will be a little difficult. So always always calculate the area of interest at from the skin, the sciatic nerves at how much depth. Usually it will be within 4 centimeters. So prick around, depending on the build of the patient, prick like 2 to 3 centimeters away from this pointer. Popliteal sciatic, this is a video showing popliteal sciatic in plane approach. You can see my pointer is lateral. You can see the needle is coming inside. This is a tibial nerve and this is a common peroneal nerve. This is a popliteal artery. So you have to you have to pierce the paraneural sheath and bring your needle tip in between the two components of the sciatic nerve. Drug is injected. You can see the drug is spreading in between the two components. As you can see here, while giving the local anesthetic, there is no swelling of the nerve. This is the epineurium of the nerve, and epineurium is not breached. So you are giving only under the paraneural sheath. This is a continuation of that video. So now you can see both the tibial nerve and the common peroneal nerve entirely surrounded by the local anesthetic. Yeah. So there's a post-block scan I'm doing to identify the spread of the proximal and distal scan. This is almost at the mid-thigh level. Can you see this single sciatic nerve surrounded by the local anesthetic? This before its division. Yeah, now it is dividing. So this is a post-block scan image. I can see the popliteal artery, popliteal vein, tibial nerve surrounded by local anesthetic, and there's a common peroneal nerve surrounded by the local anesthetic. Yeah, this again a post-block scan video. Yeah. You can see the common peroneal nerve. From distal, I'm scanning proximally. You can see the sciatic nerve surrounded by the local anesthetic. And the nerve is divided now. Coming on to the out of plane approach, you can this picture showing the needle entry point for out of plane approach. Usually there will be a black mark in the high frequency linear transducer. So that corresponds to the center of the footprint. That corresponds to the center of the screen also. So always keep the area of interest sciatic nerve in the center of the screen and pick in the black mark. In out of plane approach, again this patient is in the lateral position. This is a pre-block scan. You can see the common peroneal and the tibial nerve. Almost joined. So yeah, it's almost joined now. So this is the you can see the out of plane approach. You can see the needle coming inside from here. Initially, hydrodissection was done, but that is in the subepimysial compartment outside the paraneural sheath. The next injection was given inside the paraneural sheath. As you can see here, there might be a Cocu septum here, so you can see the drug spread only is in the tibial component of the nerve. So the needle is withdrawn and redirected to the common peroneal component. Yeah, now you can see the spread on both the compartments of the nerve. Yeah, again the after block picture, so anatomy picture showing tibial nerve and common peroneal surrounded by the anechoic local anesthetic. This is another video of out of plane approach. So here the orientation marker is kept medially. So this is your tibial nerve and this is a common peroneal nerve. You can see the drug spread. Yeah, you can see now both the tibial and common peroneal component is entirely surrounded by the local anesthetic. This is called as the donut sign. This is the post block scan video. You can see the tibial nerve and the common peroneal here. Again, the orientation marker is kept medially here. This is a tibial nerve and common peroneal coming and joining. And you can see the local anesthetics around it. Coming on to the complications, in PNS guided, there can be a vascular puncture. So that means your needle is too medial or too deep. So withdraw and redirect accordingly. And then there can be a nerve injury that might be because of through the needle, or it can be due to local anesthetic chemical toxicity also. And infection, if you're doing a continuous catheter, it is more common. So you have to catheter care is important. And then delayed recovery can happen in popliteal sciatic nerve block also, especially if you're using a higher concentration and you're using a perineural additives. And pressure necrosis of the heel is common since like you're having an insensate sensitive limb, so the patient has to be advised accordingly, and foot pad and heel padding and all has to be kept. And then another point, as Dr. Madan told, there will be delayed detection of compartment syndrome. So again, this happens if you're giving higher concentration and if you're using additives. So in our institution, it is for anesthesia blocks and all, we won't be giving for sciatic nerve block, we are not using additives. Even without additives, in some patients, it can the block can work for even 48 hours. So you have to keep in mind that. Thank you.
Thank you, Dr. Vinod, for your excellent presentation, and very elaborative, and it's right from the basics. We don't get any questions in the chat box. I think you explained very well. I have only one query related to the onset of action of this block. Is there anything which can be done to make this block act very fast? Because whenever we do block this popliteal sciatic nerve block is the one which takes a lot of time to act on, to get the motor block nearly 30 to 45 minutes. Is there any way to?
So if you're giving exactly at the point of bifurcation, the onset of action is faster, sir. And they can use lignocaine also, like lignocaine. And the first point, the onset of action is like the toe movements will be the first to gone. So that means that is the onset of action. The block will be acted. So the toe movements, this fingering of the toes will be will not be there. So at the level of bifurcation, so even if you give above or even below means obviously this two divisions, so it takes even more longer time to act. So at the level of bifurcation, when there is a small space, that space if you target for better. But obviously, generally, regional anesthesia blocks, like you need adequate time, sir. You need a separate block room, and also.
Yeah, that is one observation of popliteal sciatic nerve block is always there is a delayed onset compared to upper limb blocks or other.
Yeah, that is because of connective tissues are more. Generally, lower limb blocks are a little longer onset of time when compared to interscalene. Interscalene, you can see the anechoic structures. All these are neural elements. Connective tissues are very less, so the drugs can seep into neural tissue very faster. So here you can in ultrasound itself, you are seeing only hyperechoic structures. So because of connective tissue, the nerves look hyperechoic in ultrasound. So your local anesthetic has to seep through the connective tissue, and then it has to enter into the neural element. So obviously it will take time. So and compared to upper limb, obviously it will take time.
Thank you. Thanks a lot. I think we have done with almost all the questions except for one person has asked a 4-in-1 block to Vishnu. Vishnu is there? Vishnu? I think Vishnu had left.
He's here only.
Vishnu. Okay, fine. There is a one question related to 4-in-1 block just unanswered. Is there do you want to comment on that in adductor canal 4-in-1 block?
It is given at the level of distal adductor canal, sir. You have to scan the femoral artery, and the femoral artery gives the descending genicular artery. So once it branches out, in that if you deposit the drug like at 12 o'clock position of the femoral artery to look for the anteroposterior compression of the femoral artery. So this is mainly given for posterior knee joint compartment pain, and for below knee surgeries and all you can use. Suppose first it's like sensory block. So for TBR surgeries, tibial fractures and all, we used to tend to avoid sciatic nerve block because of compartment syndrome. So in that case and all, if you give a modified 4-in-1 block like this, so it is like only sensory block.
Yeah,
distal adductor canal only. It's a distal adductor canal block.
Yeah, I don't. Thank you. We don't have any other questions. Sir, Edward, sir, you want to add up any points?
No, sir. We can conclude.
Thank you.
Thank you. Thanks a lot to all the speakers for their wonderful lectures today. Thank you, Edward, sir, for the opportunity. Thank you.
Thank you, Rajesh, sir. Today, the 3 lectures were excellent, and I have received many appreciation from our country and outside the country also. I thank the today faculties, Vinod, Vishnu, and Madan, sir. And also I thank the coordinator, Rajesh, sir, for excellent discussion, knowledgeable discussion. Thank you, Ananda. We will meet the next week with another interesting topic. With that, we will conclude this session. Thank you, sir. Thank you. I thank the A1 Logics and also the Anaesthesia TV, Akrulla, and sponsors. Thank you.